Hello, and welcome to another webinar presented by Axxess. We are very happy to have you a part of this webinar. Axxess is a firm believer in continuing training, and we create content that you can access anywhere, anytime, to help you succeed and grow your business. Now, before we begin, I'd like to give you a little background about Axxess. Axxess is a technology company that provides innovative solutions to health organizations to effectively run their business. Now, we empower healthcare organizations like yours with easy-to-use, cloud-based software that integrates all aspects of your operations, so you can improve patient outcomes while growing your business. We're the fastest-growing home health technology company in the country today, trusted by more than 6,000 healthcare organizations. Over 150,000 users log in daily, serving over 1 million patients nationwide. The most successful home healthcare organizations trust Axxess. Axxess has achieved many firsts in the industry. Now, we're the only healthcare technology company approved to award continuing education units, CEUs, by the American Nurses Credentialing Center, and also the most recommended home healthcare software by Software Advice. Now, we're the only company to have a native mobile app that works on both Apple and Android devices. And Axxess is the first software company approved to provide CAP services. Now, as promised, let's start today's webinar.
Hello again from Axxess. This is your trainer, Jennifer Gibson here. We're getting ready to train you today on Part 3 of our ICD-10 webinar training series. Part 3 is going to cover your coding of respiratory conditions. And again, this is Part 3 in a 12-part series called Navigating the Highway of ICD-10-CM. I'm Jennifer Gibson. I work here at Axxess full-time. And I work in the education department. Before I came to Axxess, I was a veteran of the home health field, where I've worked in every position from clinical nurse out in the field, staff nurse. I've been a case manager in the office. I've been a case manager on the road. I've been, you name it, QA. I've done director of nursing, administrator. I tease my classes and tell them I've done everything except therapy, and I wasn't licensed for that. But I did work as a liaison for the therapy department in Nashville, Tennessee when I worked there. But I am now with Axxess going on almost 4 years, and teaching is my passion, so I'm glad that you're here with me today, and we're getting ready to learn about coding respiratory conditions in ICD-10. Let's go ahead and get started. So your objectives for today are to understand why proper coding is important, to learn who is responsible for applying and assigning diagnoses. We're going to study guidance for coding respiratory conditions in ICD-10, and then we'll apply the knowledge that we've learned to common respiratory home health scenarios. So the first thing you need to know about when you're talking about coding in general, we often think about coding as a separate entity, but because we're coding on an OASIS, the OASIS C1 guidance manual actually tells us or gives us information on how we're supposed to code and how that affects our OASIS. So according to the OASIS C1 guidance manual, ICD-10 coding must follow the official guidance for coding and reporting. Now, where does that come from? The official guidance for coding and reporting on the ICD-10-CM code set is developed by CMS, which of course is the Centers for Medicare and Medicaid Services, and NCHS, which is the National Center for Health Statistics. So each year, that guidance is updated. If they need to add new guidance or change codes or anything at all, that guidance comes out generally in October of each year. And we have to, according to the OASIS C1 guidance manual, in order to code properly or fill out the OASIS properly, we are required to follow that official guidance. So where do you get that guidance? You can get it from CMS's website. You can also get it, it's always published in the beginning of your code books that you buy each year. Now, ICD-10 coding rules and sequencing guidelines must be followed, and we go on to find out in the OASIS C1 guidance manual that when we're looking at M1021 and 1023, you know how we have to rate the symptom control 1, 2, 3, or 4. We are told in the OASIS C1 guidance manual that we are not supposed to use that information when we're considering how to sequence. They actually give us some guidance on what we are to sequence, what our criteria is for sequencing the diagnoses in column 1 and M1021 and 1023. So, according to the OASIS C1 Guidance Manual, again, the primary home health diagnosis should be the chief reason the patient is receiving home care. Now, and we also know that that chief reason for home care is the diagnosis most related to the current home health plan of care, and that it can only be a current diagnosis. We are to only use current diagnoses. So let's talk about that a little bit. Number one, the chief reason patient is receiving home care. Not only do we have to figure that out as clinicians in the field, but that primary reason for home care must also match our certification and face-to-face encounter, our referral information sent over by the doctor. So I say all of that just to reemphasize what CMS has been telling us, and that is that as an agency, we need to make sure that we have the documentation from the facility from which the patient is discharging or from the referring physician with all of that outlined, all of the certification criteria outlined, why the patient needs home health services, are they homebound, what particular skill services does the patient need, and what disciplines are going to be providing that home care service. So again, when you get all of that information into your office on referral, you should already have some indication of the primary reason you're going to be going to see the patient. And so that primary reason, the chief reason, should most times also be the primary reason for home care. So saying all of that is just to reemphasize that when you get your referral information, the information that you have as far as from the physician or the facility telling you the main reason you're going out to see the patient should also match the main reason for home care in M1021 primary diagnosis on your OASIS. Occasionally, that will change because the coding guidance may tell you that you have to code something else first, and that's a sequencing rule. And if that is the case, then our OASIS C1 guidance manual tells us, of course, that we are to follow the coding guidance, and that's why that's so important, why we actually mention that. Okay, so now that we've kind of figured out what the primary home health diagnosis is, what about the secondary diagnoses? The secondary diagnoses are those diagnoses that are listed in 1023B all the way through to the end of all of your diagnosis coding there. Those are called secondary diagnoses, and they are comorbid conditions that exist at the time of assessment of the patient. Now, anything that you code as far as secondary diagnoses should actively be addressed in your plan of care, or they may have the potential to affect the responsiveness to treatment and rehab prognosis. So when you're putting a secondary diagnosis in, remember you need to be addressing that in your plan of care. By that I mean it may be something as simple as to assess, let's say that the patient has diabetes, but it's well controlled and they know their diet and they know how to check their glucometer, their blood glucose checks, all of that information they know. But you're going to put diabetes down anyway. It may not be number 2 or number 3 in the list of diagnoses. It may be number 6 or 7, but we have to do that because it will affect the responsiveness to treatment and rehab, or have the potential to, especially if it's not well controlled. So we would put that down as a diagnosis if it were applicable to our patient, and we would have to address that in our plan of care. Something as simple as perhaps saying that we will assess the patient's glucometer log every visit and notify the physician if there are blood glucose readings over 200 fasting or whatever, but you need to address those. So who is supposed to select the diagnoses? Now, I know I bring this up because oftentimes in my history of home care, the practice has been that the clinician would write up a beautiful narrative admission summary telling what was going on with the patient and all their history of diagnoses and all this kind of stuff, and they would turn that in, and then whomever does the coding would literally go in and choose the primary and secondary and put everything in sequence for the clinician. But according to the OASIS C1 guidance manual, as we see here, the patient's primary and secondary diagnoses must be made by the assessing clinician. So that assessing clinician is expected to understand that patient's overall medical condition and their care needs before selecting the diagnoses. And we also know that diagnoses are based on the assessment findings, the medical record, and input from the physician. Now, all of that, again, when you think about what CMS is doing with home care now and what we've always supposed to have been doing, we, as assessing clinicians, that initial contact, of course, we review the records from the facility or the physician, but we also go in and do a thorough assessment in the patient's home. And when we leave that patient's home and have gathered all the information, we may or may not have continued questions. That's why CMS gives us that 5-day window to complete our OASIS assessment, right? We may have to make a phone call and get more information from the physician. We may have to get a complete medication list or find some medication bottles that the caregiver may have so that we can review those and so on. So all of that is gathering the information that we need so that we can make a full assessment of the patient and what their overall condition is and what we need to be doing and formulate our plan of care and so on. And part of that ties into the OASIS C1 and how we code. So the person who goes out and sees the patient according to CMS's guidance in the OASIS C1 manual should be the assessing clinician. So we should be figuring out what goes in indicator number 1, primary diagnosis at M1021, and then the secondary diagnoses in M1023. According to the OASIS C1 guidance manual, again, the assessing clinician should record the primary and secondary diagnoses in M21 and 1023, and then the coder can add the actual diagnosis code after the assessing clinician has determined the primary and secondary diagnoses. For example, you're the assessing clinician and you might not know that the correct COPD unspecified code in ICD-10 is J44.9. So you just put in 1021 COPD unspecified, you write that part in, and then the coder can actually come in and add J44.9. That's what they're explaining here. So it can still be a tag team effort, but as far as choosing and sequencing the diagnosis itself, that should be up to the clinician in the field. All right, so how do we know the criteria for choosing that primary diagnosis? When you're trying to select the correct code, we're going to consider the following criteria. Number 1, it must comply with coding guidelines. We've just covered that. There's official guidance that comes out yearly, and we must comply with that. We are to code only unresolved diagnoses. Now, that is like if your patient goes in and they have cholelithiasis and they require a gallbladder removal. Okay, so the patient comes home to home health care. They don't have any kind of complications of surgery. We're simply going to be there short term to manage pain and assess for any signs of infection and so on. Then that diagnosis, the cholelithiasis, has been resolved. So what are we seeing the patient for? We're seeing the patient for aftercare following surgery of the gastrointestinal system. That's what we code because the condition has resolved. This is also the reason that we in home care do not code strokes, because if you think about the etiology of a stroke and the manifestations and all of that, the stroke part is when the blood loss to the brain is occurring. Once that has already happened, you are now dealing with the effects of the stroke. So we would never have a patient on services who is actively having a stroke, and therefore you wouldn't anticipate seeing a stroke code. In home care, we will always now code sequelae, or what we used to call late effects in ICD-9. We code sequelae of strokes and whatever those sequelae may be, like hemiparesis or speech impediments, dysphagia, and so on. All right, so now it tells us also in the third point here, we're going to code only the relevant medical diagnoses. We're going to code only the diagnoses that are supported by the patient's medical record documentation. Now, when they're talking about diagnoses supported by their medical record documentation, we mean the information that we've obtained from the physician. So we should have something in the medical record from a physician or a facility that backs up every diagnosis that we use. If you have some questions about what's documented, maybe you think you've got a more specific diagnosis than what's documented, then you could call the physician and query, find out more information. And if they tell you, yes, it actually is systolic congestive heart failure, for example, you would document, and legally, in order to document properly, the time and date that you called, the person's full name and title to whom you spoke, and the information that you received. Once you've done that in a communication note, you can then either put it on your 485 plan of care and have the physician sign it, or if it's after the fact that the 485 has been written, maybe it's on a resumption of care or something else, or you get info later on that you can use at the next cert period, then in that case you're going to write it on an order so the physician can actually sign it, depending on your agency's protocols. We are told that the coding criteria, we are to ensure compliance with sequencing requirements. And if you need more specific information on sequencing requirements, you need to go back to Part 1 of our ICD-10 series, which covers a lot of the codebook information like sequencing rules and so on. And then you are to ensure etiology and manifestation codes are sequenced and reported properly. Again, that's covered in Part 1 of the series. And then to avoid non-specific or ambiguous diagnoses and symptom codes when possible. Now, if all you have is symptom codes or symptoms from the doctor, then sometimes that's all you can code. For example, if you have a patient who's referred to you, and where I'm from this used to happen every once in a while, in the deep south where I'm from in Mississippi, oftentimes octogenarians were quite proud of the fact that they'd never been to the doctor. They'd never been in a hospital. So you have 80-something-year-old people running around, and they finally start falling or whatever, and they go see the physician, and the physician does a test and, diagnostic exam and realizes, I think this patient may have Parkinson's. That's what's causing the fall. But they've never been to a doctor before, so we have to do a workup. I'm going to send them to the neurologist, and in the meantime, we'll go ahead and send this patient some home health care out, get some physical therapy and occupational therapy started for the patient, and so on. Now, you don't have a definitive diagnosis at that time of Parkinson's. So on your plan of care and your OASIS, if the patient's appointment's not for another couple weeks, you may be able to only code things like tremors and falls. And then once that information, they go and see the neurologist and the doctor sends you information for Parkinson's disease, you can go ahead and make a note of that. And if the patient should go to the hospital and you do a resumption of care or whatever the subsequent OASIS might be, you could then record Parkinson's. But because it's out of that 5-day window, when you get that information, you could only code symptom codes at the beginning on your start of care OASIS. So that's an example of what we're talking about. You might have to sometimes code symptoms, but if it's at all possible, you don't want to code that. Again, the primary diagnosis selection here on slide 8, the criteria for that is, again, that it's most related to the current home health or hospice plan of care. If more than one diagnosis is being treated, the diagnosis that represents the most acute condition and requires the most services should be assigned as primary. Again, it's the chief reason for home care, and it requires the most intensive skilled services. And finally, it is not a Z code unless necessary, and that's talking about the use of 1025B for home health. Now that column B over by 1021 and 1023, as you're going down the M question for diagnoses, to the right there are several columns, and 1025B is the column to the right of 1021 and 1023, and those are there in case you have to use a Z code or a status code as the primary diagnosis, and that actually replaced something else. For example, we just talked about the patient who had cholelithiasis, and now we're doing aftercare for surgery on the GI system. You can do your Z code aftercare in 1021A, and then over in 1025B, you could then code the cholelithiasis there. Now, it is not required that you do that. Matter of fact, CMS has told us they don't even use that 1025B for any reason, not for risk adjustment, not for payment, or anything else. So, matter of fact, they don't even look at that when you send your bill in. So I'm not sure why they still reference that as something that we use, or why they even left it on the OASIS C1. However, if that's your practice and that's your processes and your protocol for your agency, you can sometimes use a Z code primary, or the resolved condition would go over in 1025B, okay? All right, for secondary diagnosis sequencing, what are you supposed to choose for your secondary diagnoses, and how are you to sequence those? The secondary diagnoses would be diagnoses that didn't meet criteria for primary diagnosis. They are diagnoses that are addressed in the plan of care and affect the patient's responsiveness to treatment and rehab. And then you're going to list those or sequence those in order to best reflect the seriousness of the patient's condition and to justify the disciplines and the services provided. So if you have multiple codes that would go between B, 1023B and C and D, E, F, G, and so on, and you have multiple disciplines, nursing, PT, OT, and so on, and perhaps the patient, you're doing sequelae of a stroke, the nurse is in, PT is going to be going out for treatment of hemiparesis, and then speech therapy is going out for dysphagia and aphasia. In that case, if speech therapy is going more often than is PT, you would want to sequence those speech therapy codes that are related to speech therapy higher than those PT-related codes, for example. That makes sense, okay? We're going to do quickly a review of general coding guidance, and I do mean a quick review. If you have questions regarding the coding guidance that we're about to go over now, again, please go back to the first in the series of ICD-10 coding, because the first of the series is where we talk about and teach you on all the different coding guidance and rules and things in the Codebook and so on. But for general coding guidance, just as a reminder, you should always, always, always start in the alphabetical index of your Codebook. The dash at the end of entries there mean that additional characters are needed, and then you'll also see some guidance. If it says C or C also, take that as a command, because what that's telling you is there's also information at this other entry, and it may give you more detail as far as what you need than is the entry that you're looking at. So make sure you check that guidance. Then you're going to look, once you have a code in the alphabetical index, you're going to then double check the code in the tabular index. And the tabular is the chapter part of the book where codes are grouped together by perhaps their system of the body. Once you get to the tabular index, you need to check for guidance at the block level, chapter block level. For example, I-10 through I-15, that's all the hypertension and hypertension heart disease codes in ICD-10. You would look for guidance there. Then you also look for guidance at that 3-character category level and the final code level. And again, if you have questions about that, please go back and reference our first part of this series. Now let's get more specific into some general respiratory guidance. Now, as you get through the respiratory chapter of ICD-10 in the Codebook, you're going to notice that there are includes and excludes notes, and if you don't know what that is, again, go back to part 1. All of that is explained in part 1 of this series. But it's really important to read your includes and excludes notes under your respiratory codes. The reason for that is often there are multiple coding and sequencing issues to pay attention to. There's a risk due to smoking. Many involve infections, and there's manifestation codes and so on. So there's information that tells us, for example, to use additional codes to mention if the patient's a smoker or had a history of being around tobacco smoke or they used to smoke themselves and so on. And we're going to look at that in just a moment. Some other respiratory coding changes from ICD-9 to ICD-10 include the codes in J44, which is other COPDs, and J45, which is asthma. And those code sets distinguish between uncomplicated cases and acute exacerbations. COPD, of course, is chronic obstructive pulmonary disease, and it's often associated with chronic asthma, chronic obstructive bronchitis, and emphysema. Now, if you don't have information in your documentation from the physician or the facility as whether or not this is chronic asthma versus chronic obstructive bronchitis or emphysema, then you're going to use code J44.9 for COPD unspecified. That's the code you'll always use when information does not specify the type of COPD the patient has. We are not to use R06.89, which is respiratory insufficiency, with COPD codes. And why is that? Number one, R codes, remember those are symptom codes and they are rarely used. That's why they start with an R. But we are told in the official guidance that we are not to use symptom codes when the symptom that we see is directly attributed to a condition that we're coding. And in this case, all of our COPD patients are going to have some respiratory insufficiency of some kind. That's part of that disease process. Therefore, we do not code also an R06.89 because it's redundant information. That information, or the respiratory insufficiency, is directly related to COPD, and therefore we don't code that as well. Respiratory coding in ICD-10 is a little different as well, because in ICD-10 we have to differentiate as to whether certain respiratory conditions have an acute exacerbation or not. And I know a lot of us are thinking, but we've always done that in ICD-9, but really we didn't have a code that differentiated. We would change the date on the onset exacerbation date. In ICD-10, you actually have codes that denote if it's an acute exacerbation or not. So CMS in their guidance for ICD-10 made a big point about telling us that an acute exacerbation is worsening or decompensation, and that an acute exacerbation is not equivalent to an infection that's superimposed on a chronic condition. Although an infection may trigger an exacerbation, we can't just assume because they're on an antibiotic that this is actually a COPD exacerbation. That's what CMS told us in the guidance. So how do you know whether or not this is a true exacerbation? According to the guidance that we're given in the coding set and in the OASIS C1 guidance, again, we were told that we have to follow the official guidance for coding. What they tell us is that only a physician or the non-physician provider, that's like your nurse practitioner, can state exacerbation. So the example that I give, and quite often this would happen in home care when I was out making visits, I would go and see my COPD patient. I would assess their chest sounds, and sure enough, they have a little diminished breath sound or a rattle in their lung fields. And I would ask them, so has anything changed about your COPD? And they'd say, absolutely, I'm coughing up stuff now, and I wasn't doing that when you were here last. And I would ask, does the phlegm or the sputum that you're coughing up, does it have a color to it? And they'd say, yeah, it's kind of starting to turn a light yellow color. So what do? Of course, we good nurses that we are, we would call the physician and ask, give the symptoms and ask if they want to change the treatment at all. And quite often the physician would say, yeah, let's go ahead and put them on an antibiotic for a week and just make sure this doesn't get worse. And so at that time, the practice was common because we didn't know better, and often we try and do what we know and do the right thing, but if you don't know better, it is what it is, right? But oftentimes you would see when that research got turned in, the person in the office who was working up the research would go ahead and exacerbate COPD. And what CMS is telling us here again is you can't make that assumption. So, if I were still practicing in the field, and what I advise the people who are practicing in the field to do, when you call and get those new treatment orders, go ahead and ask at that time, are we going to go ahead and assume this is an exacerbation of COPD, or is this just an infection that's superimposed on COPD? And document what the person to whom you're speaking tells you in that regard. If they actually say, yep, it's going to be an exacerbation, record that, and then you can code the exacerbation of COPD. All right, in respiratory coding for ICD-10, there's some guidance regarding influenza coding. That's covered here on slide 15. We are told to code only confirmed cases of influenza. A physician statement is enough. We don't have to have a positive test required. We don't have to have that documented in our records. You don't have to have the lab test. Just the physician statement. We are also told that for suspected or possible or probable avian or novel or other flu types, we're going to code from category J11. That's due to unidentified influenza virus. And we're only going to code from J9 or J10 if the specific type is confirmed. What does that mean? Again, in the guidance, we see that if the doctor just says it's a case of suspected H1N1 flu, that's not a definitive diagnosis, so we're going to code J11 unidentified flu virus. However, if the physician does a flu test and they send it off and get it back, and then they confirm that, yes, this is H1N1 flu, then you're going to use the category J9 or J10 in that case, because you do have a specific confirmed type of influenza. Okay, so let's talk about ventilator-associated pneumonia and ICD-10. That's abbreviated as VAP. We are only to use this code if the physician specifically says the patient has VAP, or ventilator-associated pneumonia. We're not going to just assume because the patient is on a ventilator and they have pneumonia that that's the right code, and that's J95.851, by the way. But if you do have documentation from the physician that the patient does indeed have ventilator-associated pneumonia, and you're going to code J95.851, we're told here that we are also to use an additional code to identify the organism that's causing the pneumonia if we know that. So you're going to do your best to try and get that information from the physician. Is this Pseudomonas? Is this E. coli? Is it MRSA? What exactly is the organism causing the pneumonia? And if you're not sure about either of those points, the organism or the VAP, then you're going to query the physician, of course. And again, document the time, the date, the full title and name of the person to whom you spoke, and the information you queried about and what you found out, okay? Now let's look at some chapter-specific respiratory guidance. When you look at Chapter 10, and you are in your code book and you flip over to Chapter 10, the very first page, you're going to see the chapter blocks as far as what code set is, certain diseases within the respiratory section. But at the very top, all the codes for J00 to J99 in Chapter 10, you're going to see in red some guidance. And this applies to every code that's in the respiratory section, everything in Chapter 10. It tells us to use an additional code where applicable to identify if the patient has had exposure to environmental tobacco smoke, if they have exposure to tobacco smoke in the perinatal period, a history of tobacco use personally, an occupational exposure to environmental tobacco smoke, tobacco dependence, or tobacco use. So for every respiratory condition, if any of that applies to your patient, you are to use an additional code to identify that. So what's the difference? Exposure to environmental tobacco smoke. Maybe like myself, you grew up in a home where the patient's father smoked, and he smoked all my life. My dad did. Thank God he's subsequently stopped and quit. But I have an exposure to environmental tobacco smoke in my history because my dad was a smoker at home. So if I have a respiratory condition, of course, we will also have to code Z77.22 for me. Tobacco smoke in the perinatal period. If the patient is a newborn or a toddler or they're an adolescent, whenever, and there's a history of that person being around tobacco smoke when they were in the perinatal period, pregnant and soon thereafter, you're going to code that as well. A history of tobacco use, that's if the patient has smoked in the past and they've quit smoking like my father. He is now Z87.891. Occupational exposure is when literally the person worked in a place where there was tobacco smoke. So this is pre all the rules and regs that we have now, but in the 60s perhaps, patients who worked as flight attendants perhaps, you could even smoke on a plane back then. So they might have been exposed to environmental tobacco smoke, especially people who've worked in bars, bartenders, waitresses, and so on. Until recently, those laws were not in place where smoking was not allowed there, so they might have been exposed occupationally as well. And then, of course, tobacco dependence or tobacco use. Again, you're going to reference this back to the first part of our series where we talked about whether or not you can assume those things. We remember that we cannot assume tobacco dependence. I don't care if that patient's smoking 2 packs of cigarettes during your assessment. Only the physician can state that they are dependent upon tobacco. But we can definitely go ahead and document tobacco use if we see the patient using tobacco, okay? All right, when a respiratory condition is described as occurring in more than one site, you're going to code the lower anatomical site. For example, if it's documented that the patient has tracheobronchitis and bronchitis, you just code bronchitis because it's lower down in the bronchial tree. So you only code the lower anatomical site. All right, respiratory infection codes require an additional code to identify the infectious agent. And by the way, when you look up bacteria and such that are going to cause problems, the infectious agents, those codes will always come from B95, B96, or B97. They're not going to be an A code. The A code for the organisms are when that organism itself is an issue. The B codes are used to explain that this organism is actually causing this problem. So an example of that would be there's an A code for MRSA. That's just saying the patient has MRSA. If you're trying to explain that MRSA is causing pneumonia, first of all, there may be a combo code that says that, but if not, you would have to code pneumonia and then follow that by the correct B95, B96, or B97 code that says MRSA to imply that MRSA is causing the pneumonia. Okay? Now, many of the influenza codes have some additional guidance that tells you use additional code or code first or code also and so on. Now remember, use additional code has sequencing implications. When you see that, that means you're going to use that code right after the code that you're looking up. So if we're looking at, and I can't think of something off the top of my head, but if you look at let's say hypertension with heart failure, and it says use additional code to identify type of heart failure, in that case you would have to put the additional code right after. So you have to put CHF right after hypertensive heart disease with heart failure, for example. Code first has sequencing implications as well. So if you see where it says code first, underlying disease, you have to code the underlying disease first. Code also does not have sequencing implications, and it's sequenced according to acuity. So unless you see use additional code or code first, when you see code also, that means just code it somewhere in your list. It can be the last thing on the list and so on, because it does not have sequencing implications. And I point all of that out to tell you that in the respiratory section, you're going to see a lot of use additional code, code first, code also. All right, there's some guidance as well at J68 category, and that category is respiratory conditions due to inhalation of chemicals, gases, fumes, and vapors. We see here it says code first, so if you're looking at J68 category in your code book, in red, just below that, it will tell you code first, T51 to T65 to identify the cause, and use additional code to identify any associated respiratory conditions, such as acute respiratory failure. What is that telling you? That the J68 code would not be first, that you would also, you would have to code first the T51 to T65 code, then J68, and then after J68, you'd have to put an additional code to identify any kind of respiratory conditions, such as respiratory failure, J96.0. Now, in order to find those codes, you're going to have to go to your table of drugs and chemicals to find what it is that's causing the problem. So inhalation of chemicals or gases or fumes or vapors. But if the patient had inhaled some type of chemical and it caused them to have some lung damage, you would have to go over to your table of drugs and chemicals and find what chemical it is and the code, and that would be how you get the T51 to T65 that you're coding first, okay? Now, if you don't know how to use the table of drugs and chemicals, again, go back to the first of the series, part 1 of 12, and that's where we talk about where the table of drugs and chemicals is located and how you use it. Another thing to remember, anytime you're talking about problems and using the table of external causes and those kinds of things, tables of drugs and chemicals, you'll notice there are categories for accidental or intentional self-harm or somebody else is assaulting the patient. We are told that we are going to assume it's accidental unless the physician states otherwise. So when you're looking on your table of drugs and chemicals, again, at the top, you'll have several categories. You don't assume anything unless the physician states. Otherwise, you will only say that it's accidental unless the physician tells you otherwise. All right, so we're down to our practice scenarios for today. Let's talk about our patient here who is referred to home health nursing for continued treatment of pneumonia. Patient has COPD and had an exacerbation a week before pneumonia was diagnosed. The patient will be sent home on 10 days of oral antibiotics for Staph aureus. Assessment finds the patient smoked a pack a day for 20 years before quitting 5 years ago. And by the way, this patient is also on oxygen at 2 liters per minute continuously via nasal biprong. So let's look at our answers. We have to code pneumonia, and we learned just a little while ago that we're also supposed to code the causative organism. Sometimes it's going to be a combination code, sometimes it's not. In this particular case, we do have a combination code, and we knew that this was due to Staph aureus. We didn't have anything that said methicillin resistant, therefore we know it's methicillin susceptible, and we have a J15.211 code that is pneumonia due to methicillin-susceptible Staphylococcus aureus. And then we have, in our scenario, that the patient did indeed have an acute exacerbation of COPD, so our code for that, instead of J44.9, is J44.1 COPD with acute exacerbation. Then we have in the patient's history that they had a history of nicotine dependence, that's Z87.891, and then Z99.81 is our dependence on supplemental oxygen. Okay. The next practice scenario we have is a 69-year-old patient who has COPD, and at our research assessment visit we notice she's coughing. This sounds familiar, right? You ask if she's been coughing up any sputum, and she admits that she has. You call the physician and give report. Physician's orders are for antibiotics for 7 days. How do you code that for your research oasis and your plan of care? Remember, sequencing is based on acuity of the conditions unless you see guidance that says code first or use additional code and so on. In this case, we didn't have that, and we didn't have anything in our scenario where the physician said that this caused an exacerbation of COPD. So in this case, the M1021A J06.9 is acute upper respiratory infection unspecified. And then your next code would be the COPD. In this case, we didn't have documentation of an exacerbation, so we used the unspecified code J44.9, COPD unspecified. In this case, our patient is a 78-year-old with a diagnosis of aspiration pneumonia. He has a PEG tube and he's getting Gevity at 40 cc's an hour per pump. He has dysphagia due to an old stroke. Nursing is ordered for IV therapy via a PICC line for 3 weeks with piperacillin and vancomycin. Nursing is going to perform the IV therapy, the PICC line site care, and teach on a new PEG tube. Speech therapy is ordered for oropharyngeal phase dysphagia treatment. So in this case, we have to think about what the primary reason for care is. So if speech therapy's frequency is more than nursing, this could be a little bit different depending on what the primary reason for home care is. If the primary reason for home care is speech therapy, then that would go first. But because we're doing this intensive IV care and it's daily with 2 antibiotics, the pneumonia is still the issue, and nursing is going to be more predominant, more frequent. In that case, our primary diagnosis is J69.0 pneumonitis due to inhalation of food and vomit. And then after that, we're going to sequence our speech therapy goals and any other use additional codes or code also codes that we have. So our second diagnosis here is I69.391. That's dysphagia following cerebral infarction. And there's guidance there that tells us to use additional code to let them know what the stage of the dysphagia is affected. So that's R13.12, dysphagia oropharyngeal phase. Then we have to also code the encounter for attention to gastrostomy at Z43.1. Then we have Z45.2, the encounter for adjustment and management of vascular access device. That's your PICC line attention. And last, Z79.2 for the long-term use of antibiotics. I'm glad that you've joined me today for the respiratory coding and ICD-10. I hope that you'll join me for the next segment in our series. We're going to be talking about part 4, which is going to be cardiac diseases. We'll explore coding different diseases in each body system with the guidance that goes with us as we continue through the series of 12. But again, part 4 is going to be your cardiac diseases, and that will be coming very soon. And we'll continue to release these ICD-10 webinar training series in subsequent weeks so that you get the entire 12-part series very soon. And again, let's succeed together. We know that we went into home care most likely because we love the one-on-one contact with patients and we love the independence. But again, we love making sure that we are impacting that patient's life with a hands-on approach, one-on-one. And that's a wonderful thing. So we can succeed both in making the patients better and making our agencies grow and diversifying our knowledge. So thank you again for being with me today, and I look forward to seeing you again soon. Have a wonderful day, and thank you for all you do for our patients in the home. Bye-bye.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. At Axxess, we're proud to offer a variety of training resources to keep you in the know on industry news and updates. You can register for additional trainings and watch on-demand training videos through our software or at Axxess.com, where you can also find tutorials, online manuals, and answers to frequently asked questions. We're always just a call or click away. Feel free to call us at 866-795-5990 or email us at support@Axxess.com. All of our expert client experience representatives have a home healthcare background. They've been in your shoes and know the industry inside and out. Join the conversation and connect with us on our social channels. We'll keep you up to date with what's going on in the industry and share resources to help you grow your business and improve your patient outcomes. Thank you again for your time today and for choosing Axxess, your provider of complete home healthcare services, software, and solutions.